Dr. McCullough, thank you so much for being here with us today here on the Grant Theft World podcast. My first question to you is, why did you become a doctor years ago? Can you tell me a little bit about the reason why you got into the field that you're in today and becoming so popularized in the past couple of years?
Well, thanks for having me on the program. It's a real honor. I'm Dr. Peter McCullough. I'm an internist cardiologist and epidemiologist in academic practice in Dallas, Texas. And I have to tell you, I think as a child, I was wired to be a doctor. I always knew I wanted to be a doctor. I never wavered. From the very first time I opened up a book, I just seemed like I was wired to do it. I loved science, like all doctors. I love science, but I also love the interface between science and people and how complicated people are, in a sense, as scientific units of study. And that all along my entire career, I recognized that medicine is both an art and a science. And if we've learned anything in the last 2 years of this crisis, how much medicine really is an art and a science.
Well, it's an art, a science, and a practice and a service to others, right? So can you help the audience understand, what is the Hippocratic Oath? What did it apply to doctors back then, and how has it changed to today's standards?
The Hippocratic Oath is what all doctors basically agree to do. We basically swear to do this our entire career, is that we'll always be at the service of our patients, no matter what the circumstances are, no matter what the hour of the day is. And, the motto of the Hippocratic Oath is that we always care for patients. We help them sometimes we can't help them, and we cure them rarely. But it's interesting. We care always. And so the Hippocratic Oath is so much about caring for another individual. And the relationship that's described between a doctor and a patient, and now this applies to mid-level providers such as physician assistants and nurse practitioners, is what's called the fiduciary relationship. It means that we're in a circle together and that we rely on one another. And uniquely, the patient really puts their life in the hands of another individual. So it's a very special and privileged relationship.
What are some of the more substantial and relevant aspects of your curriculum vitae?
I went to undergraduate at Baylor University in Texas here, and then University of Texas Southwestern Medical School. I finished top of my class, a designation called Alpha Omega Alpha. That is typically the top 7% of students in the top 50% of institutions in the United States. I went on from there to the University of Washington in Seattle and trained in internal medicine at the time, and still is today, the nation's top ranked medicine program in the United States, just ahead of the Harvard programs. I finished there, and like many at the time in the 1980s, I went on for service. Many of my fellow residents went on to the Center for Disease Control to be CDC officers. I joined a rural health initiative, and I did 3 years in rural health in northern Michigan. The third year of it, I enrolled at the University of Michigan School of Public Health, and I trained in public health and in epidemiology. And then I went on for my cardiology training at what's now the Oakland University William Beaumont School of Medicine. At the time, it was the nation's largest and busiest hospital in cardiovascular disease. And we really broke new ground with a technique called primary angioplasty for acute myocardial infarction. These were very, very exciting times in medicine. From there, I had different leadership positions in Southeast Michigan. I was chief of cardiology at the University of Missouri, Kansas City. In the last decade or so, I've been in Dallas, Texas, in academic practice at a major university medical center. I'm now in private practice, but on the same campus. And so in many ways, people have asked me this question about how did I become so prepared to face the COVID-19 crisis and the SARS-CoV-2 infection. I think it's the sum total of everything I described. I mean, I had the right training in epidemiology. I had built really a tremendous both clinical and academic background. I have over 650 publications in the peer-reviewed literature. It's in the top echelon of anybody in academic medicine today. I'm the editor of the first major textbook called Cardiorenal Medicine, the connections between the heart and the kidney. I'm the editor-in-chief of Reviews in Cardiovascular Medicine. I've been with that journal for 20 years, the former editor of Cardiorenal Medicine. And so I know what I'm talking about in terms of data. I've been on data safety monitoring boards for now couple dozen clinical trials, some for the National Institutes of Health, some for big pharma and diagnostic companies. I've been very involved in clinical trials. I've had publications in the New England Journal of Medicine. And I can tell you throughout my career, I can look around the world and see my contribution to clinical medicine, my ideas and my work in groups. Doctors always work in collaborative groups. And the same really has come true for COVID-19. In many ways, I jumped in and I filled a giant unmet need early in the pandemic. And that was the early treatment of COVID-19 to reduce hospitalization and death.
All right. So given that, let's look into this COVID situation. What caught your eye first? What was important that really drew your attention way back in, was it 2019, 2020? When did you become aware of it and how? And let's get some detail.
It was 2020. And I can tell you what was going on was, in many ways, it was just astounding what was going on. Within the first couple of weeks, we basically had a shockwave. We heard stories in February that there was a few people in China that were sick. In fact, I had been to China 5 times. And so I had some Chinese colleagues contact me, and through virtual private networks, they showed me a few clips of panic in Chinese hospital lobbies and people gasping for breath and a few people passing out in the lobby. And it just looked like chaos. And I couldn't make much out of it. And I remember mentioning to family members that, boy, I said, either this is going to be the biggest overblown story of all time, or this is going to be Armageddon. And it really turned out to be the latter. So I was just kind of questioning the veracity and the seriousness of it. But when it hit, and we had a patient who flew from New York, as about my age, to Dallas, was hospitalized in our hospital, and we watched how vicious this syndrome was, including taking him to death in a matter of a few days. We realized that, holy smokes, this is a serious illness. And there was many meetings. The meetings all had to deal with hospital management, how we are going to do personal protective equipment, how we are going to keep the rooms from spreading the virus. Almost all the meetings were about playing defense, and that was controlling and how to hospitalize these people. Relatively little about what we do once somebody's in the hospital, and there was nothing on early treatment to prevent the hospitalization to begin with.
So they seemed really caught by surprise. Like they had never done exercises to this effect. This really caught them out of nowhere. They had no planning around this sort of thing. So you're right. From a public perspective, I was looking for, what are the therapeutics? It wasn't about just playing defense. It's like, what is out there? I started following Dr. Didier Raoult back in like February of 2020. I started getting my learning on reading about the PubMed articles on zinc and ionophores and how it opens the cells, and it acts just like hydroxychloroquine or chloroquine. So even as just someone who knows how to read and reason, in the absence of our leaders not really giving us a whole lot, people like yourself, people like Dr. Pierre Corey, people, Dr. Zelenko, Dr. Bartlett, Dr. Fleming, there's a whole bunch of people who started talking about what's going on here, trying to look at it from a first-person research-based perspective. I want to spend the bulk of the interview talking about the history and all the different things that goes with that's happened. But so that people don't have to wait till the end to get solutions, I want to release that fear up front. Can we talk about early treatment and the things that people could do therapeutically without getting into some sort of institutionalized bureaucratic situation out there?
It's true. I've had a variety of interviews. I remember I interviewed with Tucker Carlson. I told him, I said, Tucker, there's no Harvard protocol. There's no Mayo Clinic protocol. There's no Duke University protocol. Do you know that our top shelf academic institutions have batted a zero? They've done nothing to treat outpatients with COVID-19 to prevent hospitalization and death. They haven't tested a single different drug combination. It is stunning. These hospitals have protocols for outpatient treatment of myocardial infarction and diverticulitis and traumatic injuries. But suddenly with COVID-19, our academic institutions, we have 300 medical schools, 2,200 acute care hospitals, 5,600 hospitals overall. None of them could think up a single thing to help a patient prevent hospitalization and death. And this occurred for months. This was long before the first set of guidelines that came out that said to do nothing. In fact, people were in the habit of doing nothing. Our institutions were in the habit of telling patients, there's no treatment for COVID-19, sit at home, wait until you can't breathe anymore, then come in the hospital. So we established that practice pattern as basically in lockstep, all the institutions across the United States. And it was only independent-minded physicians like myself, like Didier Riot in Marseille, France, Vladimir Zelenko, Monroe, New York, Brian Tyson, George Freed in South Central California, Yvette Lozano here in Dallas, Richard Bartlett out in West Texas. You can name the heroes basically probably on two hands in the United States that basically took bold steps to start to treat patients with COVID-19 at home to prevent hospitalization and death. And this is the classic story of innovation. Innovation never comes from the ivory tower. In fact, the ivory tower is so slow to react to something. These ivory towers move at glacial speeds. And this is one of the incredible stress tests of our academic institutions. They were completely and totally unprepared to innovate at all. From the very beginning, they were playing defense, worrying about masks, worrying about hand sanitizers, worrying about mechanical ventilators. And no one could think upstream at all that we were going to have millions and millions of Americans get sick. And the entire name of the game was to avoid the hospital and avoid death altogether. That those were the two important outcomes. And this was a mental paralysis. We had White House Task Force 1, White House Task Force 2. We had two sets of surgeon generals. We had two presidents, two vice presidents. We had the National Institutes, FDA, and CDC. Do you know to this day, not a single official on a single occasion said the following statement, that hospitalization and death are the two bad outcomes of COVID-19. I'm going to put together a team of doctors who is going to figure out how to treat COVID-19 and stop these hospitalizations and deaths. No one said it. No one said that. And I can tell you, when a leader cannot articulate the problem and cannot articulate the goal, there is zero chance that leader is going to do something positive in the setting of a crisis. So we basically had a problem of a lack of leadership. And this was global. This was across all countries. Not a single country could articulate this problem. It was mass fear and confusion. People were reaching for masks. They were reaching for hand sanitizer. They were all over the place, but they could not focus on the sick patient right in front of them. So as people fell sick at home, what we needed an approach, again, to stop these hospitalizations and deaths. So what we learned, fast forward over about 2 years, is that the infection was amenable to risk stratification. What that meant is it didn't infect people equally. Thank goodness. We could predict with a high degree of accuracy who was going to be sick enough to be hospitalized or die and who basically didn't need any treatment at all. And the short equation is that about 25% of adults really need treatment. And it's individuals over age 50. That's where the risks for hospitalization and death become greater than 1%. And then the higher in age, we start adding medical problems like obesity, diabetes, heart and lung disease, kidney disease. We can mathematically calculate who's going to get in trouble. In fact, there are calculators now. The Cleveland Clinic has a calculator to predict hospitalization and death. Now, the Cleveland Clinic doesn't have a protocol to treat patients to prevent hospitalization and death, but by golly, they've got the calculator and it's pretty good. So we can actually calculate who's going to get in trouble. And it's only those people at high risk do we need to treat. The state-of-the-art treatment nowadays actually starts in the nose and the mouth. So we use dilute betadine or dilute hydrogen peroxide solution for oral nasal decontamination. It can be done about once or twice a day for prevention, but during active treatment, it goes every 4 hours, supported by 7 randomized trials, over 2,000 patients. The lead article is by Chowdhury and colleagues. They used dilute povidone iodine or betadine, nose, mouth, and even eye drops every 4 hours could abort the illness. It basically, an incipient COVID-19 could abort the illness 75% of the time. I have patients, as we're talking right now, with active COVID-19, and we are blasting the nose and mouth every 4 hours. We're reducing the viral load. We know with the Delta variant, the viral load is 251 to 1,000-fold more than the prior variant. So the oral nasal decontamination is very important. So we have less of that virus replicating in the nose and mouth so it doesn't move into the body. In the randomized trial by Chowdhury, 606 patients, 303 randomized into povidone iodine versus dilute saline, was enormously effective. We have supportive data from preclinical studies using other solutions, nebulized hydrogen peroxide. We gargle in the mouth, spray or nebulize in the nose. Even sodium hypochlorite, believe it or not, dilute bleach, a few drops in water, also is virucidal in the mouth. We don't recommend it in the nose and in the eyes. It's noxious, but in fact, it certainly works. So we start there. There's a good base of nutraceuticals that are assistive. They're probably not curative in COVID-19, but we recommend them. You mentioned zinc, which is an inhibitor of the viral polymerase. Vitamin D, 5,000 international units as a baseline preventive dose. But in active treatment now, we go to 20,000 international units per day in active treatment because it does work as a steroid hormone, probably is therapeutic. Vitamin C, 3,000 milligrams, and quercetin or quercetin, 500 milligrams twice a day. That's the nutraceutical base. Now, there are naturopathic physicians who are far more expert than I am that have really taken this to a whole new level, and they can use advanced doses of additional therapies there, because COVID-19, we've learned, is a tremendous catabolic strain on the body. After that, I think the premier solution, I'm working on that right now, I just got called during this interview for a patient, is a monoclonal antibody infusion. These became available in November of 2020. The United States government has purchased hundreds of millions of doses of these. Everybody should know about them. The billboard should be up in every city on where to find a monoclonal antibody infusion. We have two of them now. One is emergency authorized GlaxoSmithKline, and it's called sotrovimab. And sotrovimab is a monoclonal antibody directed against a glycosylation attachment to the spike protein. That's important because it's not subject to mutation. And it's associated with over 80% reductions in hospitalizations and death. And we need to give it early in high-risk individuals, for sure, everybody over 65, and then those over age 50 with medical problems. Or we can use Regeneron. The Regeneron is a combination of carasivimab and imdimimab, and that's two different monoclonal antibodies attached at two different what's called epitopes on the spike protein, which is the spine on the virus. People remember that because former President Trump received Regeneron. Remember that? Really a confident young doctor who took care of Trump. I love that guy. He said, listen, we're going to get the president better. And he did. He used the monoclonal antibodies and other drugs in combination, which I'll summarize. He got Cadillac treatment. We know Governor Greg Abbott, who failed the vaccine and got COVID-19. He got the antibodies. And recently, podcaster Joe Rogan, big Joe Rogan, received the monoclonal antibodies and the other drugs in sequence combination. I've been asked to opine on that on national TV. I said, yeah, Joe Rogan, he got just what I drew up for America and for the world in the two seminal publications, one in the American Journal of Medicine in August of 2020, and the second in Reviews in Cardiovascular Medicine in December of 2020. This is Cadillac treatment. Now, if we get the monoclonal antibodies, it's been my experience that we can skip hydroxychloroquine and ivermectin. We just move into using inhaled steroids, inhaled budesonide, oral prednisone if there's pulmonary symptoms, oral colchicine, which proven in the co-corona trial, 4,000 patients, double-blind, randomized, placebo-controlled trial, reduces the risk of hospitalization and death. And then high-risk patients like the one I have right now, where the oxygen saturation is going down. The low oxygen saturation is due to blood clots in the lungs, micro blood clots. Every autopsy study shows that. And so this patient is being started on Lovenox or enoxaparin, 1 milligram per kilogram, subcutaneous every 12 hours. Otherwise, we could use oral Xarelto or oral Eliquis. There, the active 4 trial was just published using one of these anticoagulation strategies, and it didn't show a difference. You know why? Because they didn't recruit patients who were at high risk. They didn't recruit patients who had a high D-dimer level or a low oxygen saturation. So they recruited very benign cases of COVID-19, and the rates of the endpoints of thromboembolic events, hospitalization, and death were too low. But I'm telling you, that's a failure of clinical trials, not a failure of the medicines. These patients indeed need blood thinners. And one of the final drugs we use all the way through, and we extend it for 90 days now, is aspirin. It's full dose aspirin, 325 milligrams. And even our Italian colleagues now report they're using 700 milligrams a day because they have that tablet size. But what I'm telling you is we use drugs to reduce viral replication. Then we use drugs to treat inflammation, steroids and colchicine, and then blood thinners, aspirin, and the more heavy-duty blood thinners to treat patients. So it's a lot of medicines, but I can tell you, compared to being in the hospital for 4 weeks and going on a mechanical ventilator, patients will take these medicines because it's a serious, potentially fatal infection. I'll say one other thing. We've heard that there is a drug coming forward from Pfizer, and that is a kinase-like 3 a protease inhibitor, a single drug target approach. That's perfectly fine. If that looks like it can be, have an addition to the protocol, we'll welcome it. I tend to doubt single action drugs are going to have much of a role. The other one is molnupiravir by Merck. That's a single action drug, which is a polymerase inhibitor similar to favipiravir, which is used in Russia and other countries, is not too effective and has the same mechanism of action, by the way, as remdesivir. So probably won't be too effective. But two of our main workhorse drugs that we use in COVID-19, particularly if they can't get the monoclonal antibody infusions, are hydroxychloroquine, one of the originals. And I wrote one of the first investigational new drug applications on hydroxychloroquine, 200 milligrams twice a day, can be extended, by the way, all the way to 30 days. And sometimes we do that. That's supported by over 250 studies, clearly showing reductions in more hospitalization and death when used early. Important, used early. And then the other drug is ivermectin. Ivermectin is a drug that is supported by over 60 clinical studies, over 30 randomized trials, seems to work equally well in the hospital and out of the hospital. Both hydroxy and ivermectin, by the way, have 3 mechanisms of action to treat this syndrome, not one.
Well, I think that's fantastic. You said some words in there that people have heard have been politicized, but ivermectin, there's a meta study, I think, of up to 67 studies now. So along with hydroxychloroquine, which has a long track record, ivermectin, which also won a Nobel Prize in 2015, these things are effective, even though they're telling us it's a virus and these are antiparasitics, and people can make fun of that all they want. But I know many, many people who have taken your regimen, and ones like that from the other doctors you mentioned, they've all survived. None of them have gone to a hospital where the protocol is high pressure, low oxygen ventilation until you don't get extubated, right? And I think that death count that they made artificially go up, that helps them push their predetermined solution, which was a vaccine, which they started working on in January 2020 before they even gave us early treatments or any of that sort of stuff. And as new treatments and therapeutics came out, it seemed that they were each demonized and demonized and demonized and demonized throughout the year. I've noticed a pattern of these things. So thank you for bringing the copious amount of information, whether it's the iodine, which is very simple, it's very affordable, it's not out of stock anywhere, to the other things that are now being sequestered, like the antibodies, which I've had relatives take, to the ivermectin and HCQ, which there are various ways out there in the world to acquire it. If it's not at the pharmacy, you got to think out of the box sometimes. I know I had looked at the myfreedoctor.com. I live in one of the 3 states they're not allowed to do business with. So I was prevented from getting therapeutics, even though I was trying to be, proactive on these sort of things and help people out. So experimenting outside of having the early protocols for these hospitals, it's something that people have to learn how to read, become educated on, not just listen to you, but also check around. They just, people need to become more educated and less dependent on what someone who's a famous doctor on TV who talks to them a lot, who they think is their friend, Dr. Fauci, has to say. It's like, we have to check, we trust but verify. How about that? Would you recommend that? Is that a safe thing to say?
I would say let's just kind of increase the skill and competency of who's giving the directions here in the United States. We cannot have people who are not board certified, who've never seen a COVID patient, who's never treated a COVID patient. This is a mass casualty situation here. If we would have had a trauma surgeon running the operation, America would have been better off. We don't have time for large-scale randomized trials that take 2 to 5 years. We don't have time for government guidelines, which will take another couple of years after there's multiple randomized trials. The Institute of Medicine says from the time something is known to work to the time we implement it, 17 years. We don't have 17 years. We don't have 17 days. We needed doctors with guts who are willing to put their best foot forward, willing to potentially take a hit with the infection. Most of the people in my circles did get COVID-19, myself included, but take some risks and get these medicines in play. And, it wasn't perfect, but we found our way with what's called sequence multi-drug therapy. We did 2 very good outcome studies, one in Dallas. Proctor's the first author, 85% reductions in hospitalizations and deaths. This is one of some of the early protocols before we had a lot of the really powerful drugs. And Vladimir Zelenko and Derwand published as well. Again, this is peer-reviewed literature. You can go find these on the consistent 85% reductions in hospitalization and death. I would say now, with the monoclonal antibodies used appropriately and everything we've learned, we probably can reduce these hospitalizations and death by over 90%. It should be very rare that anybody gets hospitalized with COVID-19 or anybody pass away of COVID-19. I've treated patients in their 90s now and prevented hospitalization and death. Every nursing home patient should be treated on the spot in their nursing home, should not go to the hospital. And as you alluded to, the great concern in the hospital is the hospitals right now are following the National Institutes of Health guidelines. And the guidelines were first issued October 8th of 2020. And they basically say that patients should receive no treatment until the point where they need oxygen. And the only treatment really endorsed is the use of remdesivir, which has very mixed data and toxicity, both hepatic and renal toxicity. And then dexamethasone, which is a low-dose glucocorticoid used in a very odd type of administration pattern. And it's very far away from our standards that we use all the time, which is prednisone and solumedrol. So other drugs that can be used in the hospital all have mixed data: tocilizumab, baricitinib, serilimumab. It's just the hospital is basically bereft of any high quality drugs used in combination. And we've said from the very beginning, listen, if we start using a multi-drug protocol as an outpatient through what's called continuum of care, all the drugs we start as an outpatient should be continued as an inpatient, and then additional things can be used. But that's not what's happening. They're actually not doing any medication reconciliation from the outpatient to the inpatient. They're stopping all the outpatient drugs if they've been started, and then they get a step down in care. So you know what patients are doing? The families are outraged. They've actually gone to courts, and they've said, listen, put my family member on full dose anticoagulation, full dose aspirin, colchicine, ivermectin, and it's shocking that hospital administrators, ICU directors, infectious disease doctors, chiefs of staff are told by U.S. courts to treat patients appropriately. I think historians will record this. What type of shame they must feel. We started with the fiduciary relationship. There's a couple important principles. One's called the principle of autonomy. If one is hospitalized, the person who's hospitalized has autonomy over the decisions made, not the doctor, the patient does. And there's another important concept. It's called shared decision-making. Whatever ideas that the doctor has, you share the ideas with the patient and you agree on what's going on. Patients are begging for ivermectin. They're begging for full dose anticoagulation, and the doctors are telling them no. It's shocking. And these doctors and hospital administrators are going to walk a walk of shame. And I think later on, they're going to walk another walk, and that's called malpractice defended.
Or Nuremberg Code of Ethics violations, or the U.S. government rules and federal laws on the books that prohibit such things as experimenting in an uninformed way on the population. There is a track record of that historically. So the two topics I want to address before you have to go, because you're a busy guy and you got another appointment. I want to talk about the history of the spike protein, but before that, I want to talk about the vaccine for kids, because now they're pushing it out for kids. I just looked at this World Health Organization document the other day that says you can have implied consent just by sending your kids to school. And if you didn't opt out, they can put these things inside you. And then I had this FDA meeting. It's a briefing document from October 26, 2021. Alex was just talking about it today on InfoWars. Vaccines and related biological products. And it talks about tromethamine. Tromethamine is a new ingredient that they put in specifically for the children's version of the vaccine. So I know that news is broken in the last 24, 48 hours since it's been circulated, but the additive of tromethamine, I think is how you pronounce it. Are you familiar with that? And overall, let's talk about the kids and the vaccines, and is it necessary, risk reward?
I've been briefed by Dr. David Wiseman, who has actually been one of the presenters at the last two FDA meetings, one regarding children age 12 to 17, now the one children age 5 to 11. Dr. Wiseman is a former J&J scientist, considered one of the top people in the world. And I was stunned to learn that the formulation that the children are going to receive, we knew it was going to be 10 micrograms of messenger RNA and lipid nanoparticles, but I was stunned to learn that the formulation is going to be changed with no testing. So now we actually have no idea that if this new formulation, A, is it going to work, meaning will it keep the vaccine viable? Will the messenger RNA be viable during the storage and distribution process? But will it have any reactions in the children's body? This is unprecedented that there would be a formulation change without any stability testing, without any viability testing, and without any safety testing, that this is just going to be tested wide open in the bodies of children. This is a buffer solution that's relatively commonly used in other products. So it's not like it's a red flag. It's not a red flag so much for safety, but boy, the audience will recall when Pfizer came out, they had to have it at minus 80, and it was all these refrigeration. Everybody was frozen carbon dioxide, and it was all this smoke coming up, and it was such a big deal to manage Pfizer. And now it's going to be rolled out with a different buffer solution, smaller messenger RNA. And lipid nanoparticle.
But it's the same protocol, because this is the emergency use amendment for children 5 to 11 age. And then it goes down and says they're going to use this buffer agent. It has to be diluted in sodium chloride right here. And then it can only be kept in for 12 hours, and it has to be kept at this temperature. So let me get that on screen there.
Yeah. So 2 degrees instead of minus 80. So the temperature is very different. And the point is, stability. So the threat here is that with this change and without this testing, we would have no idea if there's going to be any benefit of the vaccine. I'll take it at face value that it will. But what we know from the registrational trial that was just published in the New England Journal of Medicine on children ages 1 to 5, that roughly 2,200 children were randomized to 2-to-1 randomization to the Pfizer 10 microgram shot at baseline and then at week 3 versus placebo. The clinical benefit was basically minuscule. I believe it was 16 cases of COVID-19, which was nothing more than just a drippy nose or mild congestion, nasal congestion in 16 kids in placebo and 3 in the vaccine group. And so clinically, it wasn't meaningful. At that age, there's 4 to 8 colds a year. So it's no different than a cold. No spread, no family spread, no mention of a spread to teachers. About 30% of the kids got sick as usual. Fevers, body aches, muscle aches, hard to figure out what symptoms they're having, have to keep them out of school. And so from a clinical perspective, as a doctor, I make decisions every day. I would look at that clinical trial and say, the benefit isn't there to go through all this effort to try to save a few colds. It's just, even Linus Pauling said that don't vaccinate someone to save a few colds. We know overall that COVID-19 is a mild syndrome in children. Thank goodness. The CDC, by the way, on those 2 meetings and the FDA did acknowledge the estimate is about 40% of the children have already had COVID-19 through May. Jennifer Block in the British Medical Journal mid-September had data suggesting CDC and census estimates 120 million Americans overall had already had COVID. That's before the Delta outbreak. Now, Delta outbreak was a huge outbreak, and it hit younger people more than older people. Some estimate now we're up to 200 million Americans have already had COVID-19 now, and probably 80% of the children. That means relatively few children even susceptible. So we're back to school this year, and I think everybody should note no school outbreaks, none. No credible student to teacher transmission, none. The kids aren't bringing it home and contaminating family members. No, it's not happening. So here come in November, no school outbreaks. We have a clinical trial that's very unimpressive in terms of outcomes. And so we have no clinical indication to undertake vaccination in children in any form right now. And so this idea that children should get a vaccine, it's being suggested by the FDA and the CDC, which is running the program, is being rejected by parents. I was on national TV with Dan Ball, Real America. He had survey data suggesting only 27% of interested in vaccines for their kids.
Well, and then there's the added side effects, adverse events, these sort of things. Myocarditis seems to be on a rising trend. And I've seen numbers where it's like if you vaccinated 100,000 children, you would save one life from COVID because they probably had other comorbidities, but you would lose 6 lives because of the myocarditis. Is that close to what you've seen, or what have you seen?
It's very unfavorable, right? Tracy Hogue published, University of California at Davis, a child. Now she studied ages 12 to 17, VAERS and VSafe data, but it was clear in that age group, one is more likely to be hospitalized with serious myocarditis, and it is serious. We're talking chest pain, heart damage, early heart failure, and some. They're more likely to be hospitalized with a serious internal organ injury syndrome, as opposed to taking your chances with COVID-19 and never becoming hospitalized with COVID-19, since the kids breeze through it. So the Hogue analysis is clear. And on 2 occasions, the CDC and FDA heard that analysis. And the FDA agrees. The FDA in the warning say that Pfizer and Moderna can cause myocarditis. Parents ought to translate that into saying, don't use these products because they can cause myocarditis. I mean, I think it ought to be a pretty fair translation. I think the 2 things that the CDC has said, which will go down as history as being really honestly reckless, is they said the myocarditis is mild. It's mild. In fact, it's all over their materials. Anything that makes a child get hospitalized by definition and by regulatory standards is not mild. It's always considered serious, always. If it was mild, we wouldn't hospitalize them. I tell you, I've had myocarditis in my practice. I'm telling you, it's not mild. If it was mild, I wouldn't put them in the hospital. Do you see what I mean? People ought to use common sense, and our CDC and FDA ought to be thinking about this, that doctors like me in a position of authority that are senior in medicine are going to be calling them on this. You cannot say something's mild when it requires hospitalization. You can't do that. It's just every parent ought to be outraged about that reckless statement. The next thing they said is that it was rare. It was rare. And in June, they had a universe of 600 cases. They had 200 cases that they had all the data they reviewed. And they said it was rare because what they did is they divided 200 cases divided by the universe of people who took a vaccine. Well, you can't do that because unless you check everybody for the problem, you can't possibly know what the true denominator really is and what the numerator is, especially when the kids get constitutional symptoms. They get fever, muscle aches, body aches. How do you know which kid really has enough chest pain or difficulty breathing to check for myocarditis? So they don't know the denominator. And we never do that in safety data work at all. Never. We use the word tip of the iceberg. It's considered cautionary. It's considered conservative. We use tip of the iceberg. So I was on national TV. I said, this is serious, and this is tip of the iceberg. That was in June. So you can go back and find those clips. That's what I told America. That's what our federal officials can listen to if they want to listen to my opinions on this. And here we are now. We're in November. We have over 11,000 cases of myopericarditis now. 11,000 cases. This is stunning. The Tracy Hogue analysis had thousands of cases. There now are clear reports. A report by Choi and colleagues from South Korea, 22-year-old man, took the messenger RNA vaccine, is dead within 5 days of the vaccine, has an autopsy. It's clear-cut myocarditis, and the vaccine caused it. Now we have preclinical studies from Avolio and colleagues showing that for sure the spike protein, which is the product of the vaccinations, both Johnson & Johnson and Pfizer Moderna, is the spike protein, is the culprit. It directly damages cardiomyocytes, damages pericytes around the blood vessel cells. There's no doubt about it. This is not a red herring. This is directly causative. So the question on the table is, will parents or even children who actually may make their own decisions now, are they going to take an injection of something that's directly causative for heart injury that's potentially fatal, as opposed to risking getting something that's probably less than the common cold? How will the human mind factor in that trade-off?
Could an acute manifestation of this myocarditis precipitate as a heart attack in people?
It's similar to a heart attack. Now, the blood vessels, the large blood vessels, the epicardial coronary arteries are not blocked, but it's heart damage. And we know that because we see EKG changes. And then importantly, we measure troponin. Everybody should know the word troponin. That is a blood test for heart damage. Parents ought to get to know this word troponin. It's a test that we rely on in cardiology testing. But in general, a cardiac troponin can rise above the upper limit of normal. And of course, the units are always relative as we've changing our standards from what's called contemporary sensitivity to high sensitivity troponin. But to give you a general reference range, a heart attack could be a troponin going from 1, 2, 3, 4, and then on the way down. We see troponins in myocarditis of 50, 60, 100. It's much higher than a myocardial infarction. And by the way, it's much higher than any troponin elevation we would see in a sick adult with COVID-19 in the ICU. It's been claimed that COVID-19, the illness, is associated with troponin elevation. There's been papers in the New England Journal of Medicine and elsewhere, and I can tell you, there are two different syndromes. The little mini rise we see in troponin in sick ICU patients, we see with pneumococcal and streptococcal pneumonias, staph pneumonias, and sepsis. That's nothing. That's not the same thing as vaccine-induced myocarditis, which is basically almost a fulminant syndrome in some of these children. And sadly, some have died. There's already been some autopsies and death certificates I've been asked to review, and more cases will come out. I can tell you it's not easy on the back end. I've tried to make this syndrome go away. We have to use a variety of drugs without any randomized trials. If there's early signs and symptoms of heart failure, we have to use drugs called renin-angiotensin system inhibitors and beta blockers to try to prevent the development of heart failure. And then hopefully get the child through this illness. We need serial blood testing, echocardiography, EKGs. During this time, the children can have no physical activity. So we have to be very careful. And then hopefully after 3 months or 6 months or longer, they come out of this and don't end up with any permanent heart damage. I mean, I can tell you what parent or child wants to go through this. This sounds like a pretty rotten fall semester or winter semester or spring semester. It's not worth it. I can just tell you as a doctor, it's simply not worth it to try to take a vaccine and have a child go through all of that. And people say, well, it's rare. It's rare. That doesn't make it any less acceptable to the parent and the child who gets afflicted with the syndrome. It doesn't help the 11,000 people who've already been through this. I mean, that's not right. So this idea that it's rare, just kind of do it and, do it for the team because it's rare. It's like, no, we don't accept that in a civil society. We basically look for safety in everyone. Safety comes first. And if products can't be safe, we don't use them.
That's fantastic. And in respect of your time, instead of me trying to cover this, what is a furin cleavage site and what makes this different than the other, I'd like to file a part 2 of this interview in the future and be able to just have you promote whatever you'd like to promote for the next couple minutes as far as your website, how people can help. This interview will be about the early treatments, and then we can do a deep dive next time into the history of gain of function and enhanced pathogens of pandemic potential. That's the new version of it since they censored it. Go ahead. Please give people your website and how they could contact you if they were interested in learning more.
Well, for that last part you mentioned about gain of function research and how all this came together, I can tell you I'm not an expert, but I did write the introduction for the expert in the book, and it's called COVID-19 and the Global Predators. We Are the Prey. Peter and Ginger Bragan are the authors. I wrote an introduction. Dr. Lee Vliet and Vladimir Zlenko also wrote introductions. That has 1,000 citations. That's the most referenced, highest quality book of evidence of the timeline of how this was planned and executed, basically as a global plot to execute mass vaccination on the world. COVID-19 and the Global Predators, We Are the Prey. I think it's #1 now in Amazon Medical Books, and it is flying off the shelf. I had a patient today bring it in and ask me to autograph it, if you give you any idea of how people are reading it. And it is, I think, really the just beginning of the story of how complicated this is. Who are the stakeholders who are benefiting massively from this? One would be able to have this, in a sense, better understood. And then you can follow me on America Out Loud, Talk Radio, the McCullough Report. I post a weekly report. I interview experts from all over the world, many of whom we've talked about on this interview. So if you want to hear from them directly, I intentionally go international on McCullough Report many times because this is a worldwide crisis and Americans are seeing no international collaboration. They're not seeing any window to the outside world right now. The world is closing around us right now. People are basically miserable with these vaccine mandates, and they're just being miserable in their little micro world, and they can't see what's going on in the outside world. And then also, I'd encourage you to go to Truth for Health Foundation, truthforhealth.org, and that's a wonderful website for the home treatment guide, for more resources, lots of information on vaccine safety and efficacy. And it's a great way to get involved with philanthropy, as well as being on email listservs, etc.
Dr. McCullough, thank you for your service to humanity, for your courage and your intrepid nature. I bet your family loves the intrepid nature that you bring to this life. Have a great Thanksgiving and holiday season. I appreciate your time so much. Please have a productive and healthy rest of your day.
Okay. Thanks for having me.
All right. Thank you.
Conspiracy is a story of history. It's the story of plunderers taking care of people who produce. They claim to take care of them through government, which doesn't give you anything. It doesn't take away first. So it's not creating something out of nothing. It's very real what they're doing. They're taking your rights or taking some people's rights and adding more to someone else's rights.
If you haven't heard about our Grand Theft World community membership, here are a few of the things you've been missing. A mobile app where you can access replays of the Grand Theft World podcast and show notes. Access to the Grand Theft World community on Discord, where we crowdsource news and resources, and you can contribute to the show. The opportunity to participate in the Grand Theft World bi-weekly town hall. Exclusive content from Richard Grove, including behind-the-scenes footage and future access to unpublished material. 93 episodes of the Peace Revolution podcast, and the Grand Theft World newsletter delivered straight to your inbox each week. If you want to stay ahead of the great game, visit us at grandtheftworld.com, click or tap the button in the top right-hand corner, and join a vibrant community of researchers blazing a new path to truth. We'll see you there.